Okay, so today we're going to talk about the musculoskeletal system and some of their disorders. We're going to talk a little bit about normal, healthy musculoskeletal system functions, but we're mainly going to focus on disorders and a lot of commonly things that you'll be asked throughout NCLEX and to recognize in your patient population. Here are the learning objectives by the end of this module and by the end of your ATI modules. So you should be able to answer or discuss all of these objectives by the time you take your next exam. Okay, so we're going to start with the basics. The musculoskeletal system is our body's framework and our engine for mobility. Bones are not just thin little sticks that hold us upright, they're actually made up of living tissue. So the bone or musculoskeletal system helps to provide protection for our vital organs, especially our soft organs. They protect things like our heart, our brain, spleen, liver, those organs that we can't just go out to the store and buy a new one. So really important to protect our organs. They also do things like storing important minerals like calcium, magnesium, and phosphorus, and then they help to make blood cell components. So those are housed and made in the yellow and red bone marrow, if you go back to anatomy and physiology. So our bones are constantly in a state of remodeling. So weight and stress placed on our bones help to remodel itself. So our bones are breaking down old bone tissue, and that's in part by the osteoclasts. So the osteoclasts are responsible for breaking down old bone tissue. Now, the osteoblasts are the ones that are responsible for laying down new bone. This balance is crucial for keeping bones strong and helping with remodeling based off of stress or weight that's placed on those bones. Our muscles contract to create movement, tendons link bone to muscle, and then ligaments help to stabilize joints. Our cartilage is a cushion area, and oftentimes those are in the areas where bones meet. So two bones meeting in a joint area, you usually have a cartilage cushion in between. We'll talk about some disorders where cartilage is broken down or we have issues with our movement and our stability of our joints. Our joints come in different types. So there are synovial joints, for example, in the knee. This allows for more of a wide movement, and those usually have a fluid-filled sac around those joints, and that helps with cushioning. So when you're running, jumping, we want to have a nice cushion in that knee so that we're not putting bone on bone or causing damage in the knee. Other joints are fibrous joints, like the skull. We have fibrous joints there, and these are often built for stability. When we look at assessing our patient's musculoskeletal health, what's really important is going to be to get a good detailed history from your patient. I always start by asking about pain, since pain is something that we want to assess and address before we start, gathering more information, making sure we figure out if there's any pain related to their musculoskeletal system. We want to ask things about their activities of daily living. Are they able to walk? Are they able to ambulate, get out of bed, stand, those types of things, because that's going to really be able to help us to assess their function and anything that's impacting their health. Making sure to ask about prior injuries, any surgeries or medications that they're taking, specifically things like long-term steroid use, because that can do things like weaken the bones themselves. So we really want to look at safety. NCLEX also loves to test on safety, especially with the musculoskeletal system, looking at things like, is your patient able to ambulate safely? Do they have any risk factors that could cause them to fall? And do they utilize any assistive devices? So that's really important to do when you're looking at your physical assessment and kind of gathering that data when you're doing the nursing process. Now you also can do your physical assessment, and we're going to do things, not only our subjective findings, but you want to look at objective findings as well. So you can tell a lot about their musculoskeletal system just by looking at them, looking at their posture and their gait, maybe looking at their extremities, looking for any swelling or deformities. We want to do a good range of motion assessment, looking at their strength and making sure that they have all of those systems in place. Patients will usually let you know if you ask, if they have any problems moving, do they use any assistive devices like a walker or cane, and just making sure that you're always focused on safety. If at any point your patient has a problem with their musculoskeletal health, you want to make sure to use nursing interventions that focus on safety. So making sure their assistive devices are present in the room, that they're using it, they're in good working order, so their walkers aren't missing a wheel or a handle or something like that. Making sure that they have bed alarms on, false socks, those kinds of things, and making sure that they have somebody with them at all times when they're up out of bed or in the chair, just to make sure that they don't fall, since fall is a big risk factor for our musculoskeletal disorders. One other thing that we want to assess and make sure is when we're looking at our musculoskeletal system, this also can be impacted by their neurovascular status as well. Okay, so when we talk about a lot of this disorders with the skeletal system, we're going to also look at their neurovascular status, blood flow, their color, skin, temperature, and sensation in their extremities as well. So if we have a broken bone, you still need to remember that that extremity still needs circulation to it. So one thing to remember is the 6 P's. So we're going to look for any pain. We're going to look for pallor in the patient. So is that extremity pale or have any loss of color? We're going to look for pulselessness. This is going to look at their circulation down to those extremities. So always remember to check the most distal pulse on the patient that they have, to make sure that the blood flowing is good all the way down. The next P is paresthesia, so knowing if there's any loss of sensation or problems with feeling. Excuse me. Any paralysis, so that's total loss of function or anything going on with neurovascular status. Maybe the nerves are impaired or blood flow is impaired and it's leading to a loss of paralysis. And pyokylothermia. So this is typically a problem with temperature control, making sure that it's not too cold. There's no problems with the nerve sensation for temperature control as well. Now, any problems with the 6 Ps can be a sign of a serious complication, something like compartment syndrome, which we're going to talk about when we talk about fractures and breaks of a patient's extremity. So we're going to continue on with the first part of the nursing process, which is assessment. We utilize diagnostic tools for our musculoskeletal system, and this allows us to get a closer look at the system itself, since we can't see the musculoskeletal system with our own eyes, since it's deeper in the body. Plain x-rays are usually our first stop for things like fractures or arthritis. This gives a 2D picture, shows any fractures or cracks in the bones, and we can kind of go from there on treatment. CT scans are helpful if a patient has complex fractures and maybe we need to get a visualization of all areas of the bone or a deeper look at their structure. We can utilize an MRI. MRIs are usually more in-depth and detailed. These are usually excellent for imaging related to soft tissue things like ligaments, tendons, or the discs in our spine if we have any spinal issues. When we look at a bone scan, bone scans are done usually in nuclear medicine. This is a type of nuclear medicine imaging test, and it lets the healthcare provider see how active your bones are. So it kind of looks like you're turning on a heat map for bone metabolism. It usually is used for detecting areas of increased or decreased bone activity, and this will help indicate bone disease or damage much sooner than an x-ray would. Oftentimes, x-ray is after we break something, whereas a bone scan can be more of a preventative way. So usually we order bone scans for patients that have any type of metastatic cancer, osteomyelitis, which is a bone infection that we'll talk about later, or any stress fractures that don't really show up on standard x-rays. Mainly the main thing with a bone scan is because they do get a little injection of a radioactive tracer. Sometimes we have to just have some isolation of the patient while those radioactive tracers are in their bloodstream. Usually doesn't hurt anybody, but because the dosage is usually minimal and safe, but they want to make sure to drink lots of fluid before and after the injection to help flush out that radioactive tracer. And if they're pregnant or breastfeeding, you may want to have them postpone or take extra precautions. But for the most part, it's pretty safe, not too many problems. But again, it will be a scan that will show the activity of the bone itself. And we'll talk a little bit more about that in a little bit. One of the most common complaints for the musculoskeletal system that we see is back pain, and oftentimes we see a lot of lower back pain. Usually this is from a muscle or degenerative disc disease, but we also need to be aware when we're assessing the patient, making sure that they haven't had any unexplained weight loss, any weakness, loss of bowel or bladder, any fevers, or anything that can signal an infection or possibly a tumor on the spine. So for patients where we've ruled out any type of infection or tumor, we encourage things like movement, teaching proper body mechanics, and use of medications like ibuprofen, Motrin, those NSAIDs that will help with steroid-like decrease inflammation and pain control as well. For our patients with back pain and things like that, we can also talk about non-pharmacological pain relief like heat packs or ice packs and a little bit of rest. For your nursing interventions, we also want to make sure that we're focusing on our own back pain. So it's really important for nurses to understand how to prevent back pain through proper body mechanics. So a lot of things that we teach new nurses is to do things like proper lifting, use of assistive devices like mechanical lifts when we're turning and repositioning our patients, and making sure that we lift appropriately. So when you're looking at lifting a patient or a heavy object, you want to make sure that your feet and your legs are spread apart, shoulder in line with your shoulder, so kind of a wide stance. You want to make sure that you bend with your legs, not with your back when you're lifting, and really keep your back in a straight, nice alignment so that we're not tweaking our back when we lift anything. Other things nurses need to do, they also need to raise that bed up. So don't forget when you're working with your patient, raise the bed up so that you're not bending over. And that will help with proper body mechanics for nurses. Moving out to the extremities, there are a range of upper limb disorders. So some common things that you'll see out and about would be things like carpal tunnel syndrome. This is a problem where the medial nerve is compressed in the wrist, oftentimes from repetitive movement. So individuals that type a lot on their computers, or like people who knit and things where they're doing repetitive motions with their wrists, oftentimes can compress that medial nerve. And that causes numbness and tingling, usually in the thumb and the first two fingers. And symptoms usually are worse at night after repetitive use throughout the day. We can also have issues with our rotator cuff. So we have a part of our shoulder there. If there is a little tear in that cuff due to movement, sports injuries, frequent movement, sleeping wrong, or sleeping with your arm above your head under your pillow for long periods of time, can cause a breakdown in that rotator cuff. This can limit shoulder movement and can make things difficult, even simple ADLs like combing your hair. It can be difficult to raise your arms over your head and can cause pain. Oftentimes for these disorders, They will do things like surgery, medications, to decrease swelling and things like that. But most of the time they do surgery. So they'll do surgery for carpal tunnel. They'll replace or repair a rotator cuff. And so you'll need to talk about post-op care for that patient. So main things with our post-operative care is first and foremost, making sure circulation is intact. So if I have surgery on my shoulder, I need to make sure my radial pulse is strong, it's present. I've got good neurovascular checks like capillary refill, skin turgor, coloring, making sure it's warm, good blood flow to that extremity. Making sure we check nerve function so there's no loss of sensation, no numbness or tingling or anything like that. Then we look at pain control, so making sure that our pain medication is administered in that first, post-op surgery time. We want to make sure to give that pain medication before the patient starts feeling pain or it becomes unbearable. Okay, so kind of on a scheduled dose. Whereas later in the case, maybe once our patients are preparing for discharge, then we can focus on taking it just as an as-needed time frame. Some nursing interventions also can be splinting, or keeping that arm in a splint and immobile for a little while, and then looking at rehabilitation support. So you want to start off gently doing stretches and range of motion, and then progressing to some physical occupational therapy. And for physical and occupational therapy, oftentimes we will get a referral. So we're going to consult or get a referral for PT/OT to come in and do an evaluation and then get their recommendations on what the patient can do for mobility movements. So foot problems or lower level extremities can also be just as debilitating for our patient. We can see things like bunions, which are kind of an outing or a protrusion of the foot bones. Plantar fasciitis, that is very common in nurses as well, or people that are on their feet for long periods of time. That's an inflammation of the plantar muscle that goes kind of underneath your foot, all the way the length of your foot. And then flat feet are also an issue that can limit mobility. When we look at treatment or management of foot disorders, oftentimes we look at first safety in mobility, so making sure the patient can walk appropriately. Then we'll look at things like use of orthotics or assistive devices to make sure that their feet are supported. We can also do surgeries or certain range of motion exercises or stretching with physical therapy as well when necessary. So we'll talk a little bit about osteoarthritis. So osteoarthritis is the classic wear and tear arthritis. So remember we talked about cartilage and synovial joints in those joint spaces, especially in like our knees, our elbows, our hip joints. Osteoarthritis results in that cartilage being worn away through repetitive wear and tear. That joint space then narrows, and oftentimes bony spurs develop on the bone from rubbing on each other. So those bone ends tend to rub on each other. This can cause the bone remodeling, right, where our bone restructures or adds more bone on through those osteoclasts. Now, or osteoblasts, I'm sorry, osteoblasts put new bone on. Now, when we have bone on bone, oftentimes we have a lot of pain. So pain is the biggest complaint that will bring a patient in when they have osteoarthritis. Now, osteoarthritis has pain that worsens with activity and improves with rest. And that's going to be important to understand because we're going to talk about rheumatoid arthritis on the next slide. So osteoarthritis has pain that worsens with activity and improves with rest. And usually they have morning stiffness that usually eases within about half an hour to an hour once they wake up. Our care is going to focus on pain control, maintaining function or their ADLs, Looking at weight management or making sure that they are able to be mobile and don't have excessive weight that can help to break down those joints. And sometimes in advanced cases, we may have to do a full joint replacement. So again, osteoarthritis is typically in those larger joints like the hips, knees, and elbows. And we may have to look at pain control through the use of NSAIDs for pain and swelling. Sometimes we can do injections like steroid injections that are right into that joint that helps with pain. But sometimes we have to just do a full joint replacement and looking at physical therapy as well. Okay, now we're going to talk about rheumatoid arthritis. So rheumatoid arthritis is actually an autoimmune disorder. So our body attacks its own joints. Usually this is categorized by pain and inflammation in these small joints, so not the large like osteoarthritis. These small joints are found usually in the hands or the feet. As you can see in the picture there, it's an elderly person's finger joints. And so it's a breakdown of the cartilage and inflammation of those small joints caused by this autoimmune disorder. Usually for our medication or our medical management, we will do things like immunosuppression medications and steroid therapies. So that targets the swelling and also helps to decrease our immune response to our own body. One of the main medications we use is methotrexate. So that'll be one that you'll hear a lot about, methotrexate. This is used to help decrease that inflammation and helps decrease immunosuppression or helps increase immunosuppression. So our immune system is dampened down. Now for our methotrexate, this can take quite a bit of time to take effect. So usually about 3 to 6 weeks for the patient to start feeling those effects. When we talk about methotrexate, we want to make sure that we educate the patient on avoiding alcohol, since that is a contraindication to this medication. Making sure that we have them educated on signs and symptoms of bleeding, since this medication can cause thrombocytopenia. So platelet issues, bleeding. Make sure that they utilize a soft toothbrush, utilize safety razors, monitor for safety when ambulating, since we don't want them to fall and bleed, and just kind of educate on how to watch and monitor for bleeding. It also can cause bone marrow suppression because it does decrease that immune system. So if our bone marrow is suppressed, then that means our immune function is not functioning properly. So they'll have a decreased immune function. So things like infection becomes a really big focus as well. So they should avoid crowds, avoid people who are sick, maybe wear a mask if they're taking these medications as well. And then they also want to avoid the use of NSAIDs, since that can increase their risk of bleeding while taking methotrexate. With our rheumatoid arthritis, our movement, opposite from our osteoarthritis, our movement will help our rheumatoid arthritis feel better. Okay, so in the morning they wake up stiff, but as they move, then it should help to decrease the problems with rheumatoid arthritis. So having physical therapy and occupational therapy come in, show them movements, give them maybe grippy balls that they can grip and kind of keep their fingers moving is also beneficial. Okay, so next we're going to talk about osteoporosis. So osteoporosis is a chronic progressive disease where our bones kind of become Swiss cheese. So they become porous and very fragile. They have lots of little holes in them from the breakdown of that healthy bone. Now with our patients, the thing that we worry about the most with osteoporosis, again, is falling and injury. So even a small bump or a minor fall can cause our patient to get a full fracture and break their bone. So when we think about healthy bone is kind of like a solid honeycomb. Osteoporosis makes the walls of that honeycomb very thin and weak and brittle. So this happens because of our osteoclasts. Remember, they break down those old bones, and osteoblasts build new bones. So normally these two stay in balance, But with osteoporosis, the breakdown of the bones, those osteoclasts, tend to be on hyperspeed. So our breakdown of the bone outpaces the building of the bone. So our bone density decreases, the density of that bone. Our risk factors for osteoporosis, this is age. So usually our older population, especially females, they typically will have risk factors or problems with osteoporosis. These are especially women who are postmenopausal, and this can be due to hormone regulation, but can also be due to things like low calcium and vitamin D intake, lack of weight-bearing exercises, which weight-bearing puts stress on that bones and helps those osteoblasts to build new bones. We also have patients who may have osteoporosis problems related to long-term corticosteroid use or endocrine disorders as well. So usually osteoporosis is called the silent disease because there's not really any obvious symptoms until a patient has a fracture. And then when they do that x-ray, they'll see that the walls of the bones are very thin. Common fracture sites for this is going to be hip due to falling, vertebrae due to the weight of an individual and their posture, and then wrist, especially with falls as well. You might notice a loss of height in your patient or a stooped over posture. This is also known as kyphosis. This is where the individual has kind of that hump back or bent over top of the vertebrae. So you'll see that in your patient. Oftentimes for your osteoporosis, we diagnose it through the use of that bone scan where we're looking at mineral density and seeing if the bone are brittle and have a lot of holes in them. For our nursing interventions and maybe our nutrition, we want to make sure that our patient has adequate calcium and vitamin D. So calcium and vitamin D go hand in hand for bone health. We want to make sure that we increase weight-bearing exercise, things like walking, dancing, and use of light weight. So weight-bearing exercise helps put stress on that bone to increase those osteoblasts for creating bone. Making sure that we have good fall prevention at home, since these patients do have risk for fractures with falls, and then decreasing smoking and alcohol use. We may utilize medications like biphosphonates. These would be things like alendronate and ristronate. These can help to slow bone breakdown, can slow that breakdown from occurring. We also can screen our patients early on, making sure that we educate them on diet, exercise, and their home preventions, and then making sure that they have good mobility support. Again, getting physical therapy or occupational therapy in. So again, osteoporosis is those bones that are silently turning fragile, and we want to catch it early, teach prevention, and help our patients stay safe and prevent fracture. Now, when we look at osteomalacia, this is a same kind of similar thing like osteoporosis, where it's a soft bone, but this is actually a defect in the bone mineralization. So the bone matrix is there, so those structures of the bone is there, but it's not properly hardened with calcium and phosphorus. So it's kind of like building a brick wall, but forgetting to add the cement to it. So the structure's there, but it's not strong. Usually this is a cause, as I said, in vitamin D deficiency. So an individual who maybe has a poor diet of vitamin D, they have kidney or liver disease that can cause a lack in vitamin D, or not enough sunlight, okay, where we get our good vitamin D. Our low calcium level can also be a culprit, and this could be due to lack of calcium intake in the diet, but also can be a problem with that renal problems and medications like anticonvulsants that interfere with the hardening of the bone. So without vitamin D, we really can't absorb enough calcium and phosphate. So then those crystals don't make that bone rigid enough. So the bone is often soft and bendable. So your cues that you'll see in your patient are going to be things like limping or trouble walking. They may have diffuse bone pain, muscle weakness, especially the muscles that are attached to those bones, and the big muscles like your leg muscles used for climbing stairs or getting up from a tree. A chair, not a tree, a chair. Good grief. So for your diagnosis, usually they'll diagnose with low vitamin D or issues with calcium levels in blood, and they'll do some x-rays. Those can kind of show thin-like fractures that might be present there. A bone biopsy can also be needed if they want to confirm that as well, to kind of look up the structure of the bone itself. So again, for osteomalacia, it's not about losing the bone like osteoporosis. It's about the bone that's there not getting mineralized enough to be strong. Okay, so one is missing bone and one is not strong bone. Then we'll look at Paget's disease. This is a chronic disorder of bone remodeling. So again, usually bone is broken down by the osteoclast and rebuilt by osteoblast in kind of that balanced way. In Paget's disease, the breakdown is excessively rapid, and the rebuilding is chaotic and disorganized. So those new bone is often larger, but it's softer and weaker. So it's kind of like patching a wall with lumpy plaster. Paget's disease is most common in adults over 50, slightly more in men than women, but it really is kind of not understood as far as what causes it. There's somewhat of a genetic link, could be a cause of a viral infection as well, but for the most part, we just kind of see it occur randomly in adults over 50. Many patients are asymptomatic. Usually it's discovered accidentally on x-rays or lab tests, but patients will oftentimes complain of bone pain, and then we'll notice certain deformities. So bowing of the long bones in the legs is a common sign of Paget's disease. Skull enlargement in patients, so their skulls might be kind of larger than normal, or spinal curvature. So we also kind of talk about it in pediatrics. A lot of times patients born with Paget's disease, you'll see in the toddlers or the babies, what you'll notice are those bowed out legs and then a large skull. So they'll kind of have abnormalities in that. So for your Paget's disease, it's all about abnormal bone remodeling, and it's a sloppy build. So we have big, weak bones. So an abnormal proportion, and the bones are weak itself. All right, then we'll look at, actually we talked about that. We talked about osteoporosis. So let me just go back here. Okay. Okay, so we're gonna talk about something that you're gonna come across frequently in nursing, musculoskeletal infections. So we can get infections of our bone. One of the most common infections that you'll hear a lot of and you'll see frequently is osteomyelitis. So this is a serious bone infection that occurs. Oftentimes it's from a bacterial infection from staph. This includes MRSA. This is where the infection gets through the skin, oftentimes because of a skin breakdown. So we see this a lot in our patients who are immobile, who have bed sores, those stage 4 decubitus that we talked about in class. They'll get that infection in their wounds and it will travel to the bone. And then oftentimes osteomyelitis turns into a septic infection. So it goes into the blood. So we really want to catch osteomyelitis early. This infection can invade the bone, it can multiply, and it can cause severe infection and sepsis throughout the body. So make sure we pay attention to it. Once the bone tissue has that inability to fight infection, blood flow can become decreased as well. And so more tissue can start to break down. It can also occur from surgeries. So when we open the skin through surgery, that bacteria can go into that wound and go straight to the bone. But oftentimes you'll see it a lot with our diabetic patients or our patients that are bedbound with those bed sores. So that's really common to see. Parts of our bone may also die, and so our red blood cells, our white blood cells, all of the things that are made in that bone marrow can actually decrease as well. So your cues for osteomyelitis are going to be localized deep bone pain. So that's patients will complain of pain really deep down in their bones, and it's oftentimes worse with movement. Patients can have swelling, redness, and warmth over the affected area. So if they do have intact skin, you may notice kind of a reddened or tight, hot area on their skin as well. Labs will notice an elevated white blood cell count, and they may have signs and symptoms of infection, things like fever and chills, okay? Our main focus, if a patient is diagnosed with osteomyelitis, first thing we want to do is we want to get them on some antibiotics. Now, these are usually long-term antibiotics, and they're usually our heavy hitters. So things like vancomycin will probably be for your osteomyelitis. Now, with our vancomycin, that is caustic to the veins. So oftentimes this medication is given through a PICC line or a central line. So then we introduce more risk for infection with our patients. So make sure you're caring for your line, watching for signs and symptoms of infection, and really keeping that area clean. Vancomycin is also toxic to our kidneys, so it's very nephrotoxic. So we need to do good labs for kidneys, making sure we have proper intake and output, making sure they're urinating, and we see good yellow, clear urine. For our osteomyelitis, remember, we want to make sure that we do a culture before we give the antibiotic. So if we have an open wound, we'll culture that area, swabbing on the bone prior to administering vancomycin or any medication. We also want to make sure we look at positioning, so making sure that we medicate prior to positioning, so give them pain management and do careful positioning. So remember, it's an inflammation and an infection in that bone, so it can really hurt and can cause breakdown of the bone as well. We want to monitor for signs and symptoms of sepsis, which is a blood infection. Basically, that infection has spread from the bone into the blood and can spread throughout the body. Now, when we worry about sepsis, we really want to catch it early and treat it. So that's going to be antibiotics, making sure they have good hydration. So you might see a change in vital signs, decrease in blood pressure, increase in heart rate. So make sure that that's something we recognize. Your lab level for sepsis that you can draw to see if your patient is septic is usually a lactic acid level. So we may anticipate that being drawn as well. Making sure that we do neurovascular checks. So again, if there's an infection in the bone, we want to make sure the circulation is getting to the extremities, okay? Making sure we do cap refill, skin temperature, coloring, and making sure it's warm and dry and there's no problems, okay? Making sure we promote good nutrition. So we want adequate amount of protein to help with muscle healing and wound healing, and help with an increased vitamin C as well. That helps increase collagen, which will help in wound aid healing as well. If we have any problems with our wounds, remember, we go back and we get a wound care nurse to come in and deal with that part of it. We may need physical therapy, occupational therapy for mobility, because we don't want them to just lay in bed because they have a bone infection. We want them to still move and ambulate and things like that. So osteomyelitis is a stubborn infection. It can destroy the bone worse if we're not treating it aggressively. We have to treat it aggressively to prevent sepsis, right? So early recognition of those signs and symptoms of a bone infection, watching out for skin breakdown, right, that can lead to this osteomyelitis, making sure we do prolonged antibiotics and think about all the things that come with that, right? Making sure that we don't kill their kidneys with it. We're looking at their line, preventing infection, making sure we do good hand hygiene, and making sure that we catch this infection early. That's going to be the priority for osteomyelitis. Okay, we'll talk a little bit about bone tumors. So bone tumors can be primary, which is the primary location of that cancerous cell or that tumor, or it can be metastatic. So patients can have brain cancer and it can metastasize or spread throughout the lymphatic system and into the bones, and we'll see tumors that way. Again, patients really report a deep aching pain, especially at night. Maybe swelling or fractures are common with bone tumors due to the breakdown of the bone and the inability for those osteoblasts to really get the bone formed more. Management for bone tumors usually combines surgery. They may remove tumors, they may do surgery on them, radiation to shrink the tumor, and or chemotherapy to kill those tumor cells. Our main role in bone tumors is pain management, making sure we do mobility after we medicate for pain, and emotional support. Okay, so then we'll talk about hip arthroplasty or hip replacement. So this is a surgical procedure that's used to replace a damaged hip joint. So there's a problem with that ball and socket. Maybe the patient fell and broke it, or they have a breakdown due to arthritis or anything like that where that joint has to be replaced. So oftentimes we replace it with an artificial joint or prosthesis. Um, this is this can be made up of metal or ceramic, but oftentimes it's like a surgical steel that they use to replace it. Our main goal is to relieve pain, help our patients be more mobile again, and improve that quality of life. So we can see it in hip fractures, severe osteoarthritis, or breakdown of those bones. Main things we want to do is our nursing intervention. So pre-op, we want to do education, get a consent, do a really good assessment, make sure labs and everything is ready to go. And look for use of assistive devices so that we can utilize that after surgery. Um, After surgery, we want to do things like preventing dislocation. So that hip joint is not strong yet. Those muscles haven't had a chance to heal themselves. So main thing with our priority with our post-operative hip surgery patient is to avoid hip flexion beyond 90 degrees. So we want to have them keep their hip straight. Don't flex it, bring their knee up. We want to keep it straight and keep them less than 90 degrees. We also don't want them to cross their legs, so keeping their legs straight in bed. They can't cross at the ankles or anything like that because that puts pressure on that joint and can pop it out. They also don't want to rotate internally, so their feet, when they're laying in bed, should be pointed straight up and straight down. Don't rotate it inward, which can cause pressure as well. We can provide use of an abduction pillow. So that's a pillow or a wedge that they'll put in between their legs that kind of help keep their legs open and their hips from going in or out one way or the other. Keep it very straight. You also want to make sure to follow your surgeon's instructions for weight bearing after they have their surgery. Again, early mobility is really important post-op with our musculoskeletal surgeries. But with our hip patients, we want to get them up, but make sure we follow the doctor's orders on how much weight they can put on their legs. So sometimes it's no weight bearing. Sometimes it's light weight bearing where they can just toe touch and just put their toe on the ground to kind of stabilize themselves until they get to full mobility. Now, hip fracture patients, they will definitely use physical therapy. They can help teach them bed exercises, but also get them up early to ambulate. This helps decrease DVTs, blood clots, pneumonia. So you want them to do things like turn, cough, deep breathe, use their incentive spirometer to help prevent pneumonia while they're laying in bed after surgery. Um, Again, assess for any signs of infection at the surgical site. Make sure there's no bleeding at the surgical site, and make sure that you check your neurovascular status, cap refill, temperature, skin turgor, and things like that. Now with a hip fracture, this is pretty big. When they have hip surgery, you want to medicate them for pain. It is a very large joint. They're gonna have to get up and move. So make sure you give them scheduled pain medication around the clock, right? Unless their vitals say that they're not safe to do it or they refuse. but for the most part, they're going to want that pain medication that will help them get up and get moving. Utilize safety things, so grab bars, risers, wheelchairs, lifts, things like that. If they can't put any weight on their legs, you can use canes and walkers once they're kind of getting more mobile, but stay with them, make sure they're safe, watch for safety problems, okay? So infection, dislocation, falls, those are going to be some big ones with your hip fractures. Soft tissue injuries are frequent, usually in sports and with patients who have problems with mobility. So these can be things like contusions, which are simple things like bruises, strains, which are a pull or a tear on muscle or tendon, or sprains that involve ligaments. We can have dislocations, which can be areas of joints where the like the arm dislocates or pulls out from alignment with the shoulder. Usually all of this requires pretty quick attention to avoid permanent damage. So if your patient gets a dislocation of the shoulder and their shoulder's hanging out, we want to take care of it quickly, reset it in place, since it can cut off circulation and cause neurovascular breakdown or compromise. We're going to talk a little bit about different types of bone fractures. So fracture again is a break in the continuity of a bone. This can result from falling, car accidents, some related trauma. It can be from repetitive stress, which results in a stress fracture, or from a disease process, like a pathological problem from osteoporosis or a tumor. For your patient's general cues, they're going to obviously have pain. They may have some swelling or bruising over the area where that bone fracture is. They may have deformity or abnormal movement. So if you fall and break your wrist, maybe your whole arm, goes like a wave, like whoop, and you can see the deformity in the arm. They may have loss of function or inability to bear weight. So if you break your hip, you obviously can't bear weight on it. Maybe you would fall. They could have crepitus, so that's kind of a feeling of bone rubbing together or a grating sound that you might hear when they're moving. Or they may have neurovascular compromise, like numbness, weakness, loss of pulse. The patient's leg or foot may be blue or pale, loss of color, and that could be due to that bone that's broken, that's pressing or compromising the vascular space. So for your types of fractures, these are, usually kind of good to know. We have transverse. So a transverse is a straight horizontal that breaks straight across the bone. So kind of you can see it's like a horizontal break. Usually this is from like a direct blow or some sort of trauma. Then we have a linear break. So a linear break goes the opposite way. This is usually vertical break. Again, this can be from a direct blow, or it can be from a problem with bone stability. We have oblique. So an oblique fracture is angled throughout the bone, and oftentimes this bone may be very unstable. So their patient wouldn't want to do any more, movement or mobility with it. They should get treatment for that. You have an oblique that's displaced. So this is where that oblique angle break occurs, and displaced means that that bone is no longer lined up correctly. So you can see it's kind of offset. When we have displaced bones, oftentimes this can lead to an open break. So this is called an open or a compound break. This is where the bone breaks through that skin. Now, these patients have a higher risk for infection and usually requires some sort of surgical cleaning. So these patients are oftentimes taken to surgery so that they can set that bone with pins, rods, and things like that, and then they suture them up. A closed break is a simple break, and that's where that skin will remain intact. So there's less risk for infection on those simple breaks. Now, when you look at green stick Breaks are common. These are where one side of the bone bends and the other one cracks, and it's an incomplete break, so it's not all the way through. If you think about like a tree, if you pull off a branch and it's nice and green and healthy, if you try to break it, oftentimes it doesn't just snap like a bone would, but it kind of breaks off and kind of splinters up due to the flexibility of that bone. Green stick fractures are most common in children due to trauma because those bones are more flexible. So we see a lot of green stick fractures in the ER for kids who are playing, but also abuse, things like that can also occur. Then we have comminuted bone fractures. So these are where the bone is shattered into multiple pieces. So this is usually due to high energy trauma, like car accidents or physical trauma that occurs to the bones. So you can see all the little tiny bone fragments that occur in that long bone there. These patients are most likely taken to surgery where they can put those little tiny bone fragments back in place and surgically pin them or rod them or things like that for structure. For our fractures, we want to make sure that our priorities include immobilizing that area. So if you come across a patient who breaks something, immobilize that area to prevent further injury. Oftentimes we splint them, so usually using like a wrap and 2 structured sides to keep them in the position that they were found. You want to assess their neurovascular status. So again, color, temperature, pulses, sensation, and movement. Making sure we do that before splinting and after splinting to make sure we haven't cut off circulation with our splint or our wrap. Making sure that we do pain control and we can elevate the limb unless it's contraindicated, but usually we elevate the limb. That helps decrease swelling that will go to that side of break due to our inflammatory process. If it is an open fracture, you want to cover that open fracture or the part where the bone's sticking out of the skin with a sterile dressing. Do not attempt to push that bone back in. Cover it with a sterile dressing, or if you're out and about in the world and you don't have supplies, then you will cover it with something like a cup or something that can protect that wound and that bone sticking out and take them to the hospital. We want to make sure we get an x-ray, figure out what's going on. They may reduce the bone or put it back in alignment or put on an immobilization thing like a cast or a splint, or may take them to surgery for fixing. Now, when we look at fractures, we want to make sure that we pay attention to a complication that can occur called compartment syndrome. Now, compartment syndrome occurs after a fracture or a break. Once we put on like a cast or a splint, this is where it's a life-threatening emergency where pressure can build up inside of a closed muscle compartment. So the muscle in the arms and the legs are kind of in compartments and they're surrounded by a tough lining called the fascia. So this is kind of like a sleeve. If swelling or bleeding occurs inside of those compartments, like after a fracture or an injury, there's no room for expansion. So those muscles swell up and the blood swells up into those fascia and it cuts off circulation. So that high pressure can cause a decrease in circulation and cause the tissue to become ischemic. So without proper treatment, those muscles and cells that are inside of that area can die off. So we want to make sure that we assess circulation and nerve function in relation to compartment syndrome. Now, if we see that our patient has any signs of compartment syndrome, which are the 6 P's that I mentioned at the beginning of this lecture: pain, paresthesia, pallor, paralysis, pulselessness, and pyochylothermia, then we would want to notify the doctor immediately. So that's your nursing priority. Once we notify the provider, we want to then loosen any dressings, splints, or casts, okay, if you can loosen it up and get it off. If not, you want to go ahead and keep the limb, elevate it to heart level. Don't elevate it higher than that, but keep it elevated at heart level to maintain perfusion. Then we want to prepare the patient for what's called a fasciotomy. So a fasciotomy is a surgical opening of the lining of the muscles, which is the fascia. This will help the decrease of pressure, okay? So assess for compartment syndrome. That's the pressure that kills that tissue. And we want to do early recognition using the 6 Ps and notify the doctor immediately so that we don't lose the limb with compartment syndrome after a fracture. For traction, sometimes we need special setup to help prevent mobility or movement of fractures. Sometimes we need tension to be placed on those bones to help with remodeling, so the osteoblasts formulating new bone. So we may have to put what's called traction on the patient. So this is the use of ropes and levers and pulleys that you see there in the picture, and this helps put a counter pressure on your patient's limbs if they have any surgical fix for fractures or anything like that. Again, these patients need circulation, skin integrity checks, making sure to turn and reposition them. If they have any pins or any external fixation devices on the outside that help with traction, you would want to look for any signs of infection on the outside. So any green or pus areas or drainage around the site of fixation devices. Okay, so sometimes we're not able to fix a fracture, we're not able to fix a musculoskeletal injury, and so sometimes we have to amputate. So amputation, whether it's from trauma or vascular disease or infection like osteomyelitis, this requires meticulous wound care to prevent further infection, making sure that we manage any phantom limb pain. So when a patient's limb is removed, they can still have the nerve firing throughout their limb where it feels like they still have that limb attached. They can also have pain in something that's not there. So it's called phantom limb pain. They can have significant emotional needs because they've lost their limb. So they may need the use of a prosthetic device. Now, prosthetic devices, they can't use them right away. We have to make sure that the site of removal, so that surgical incision, we have to make sure that heals up totally. There's no open wounds or anything on the patient's limb. Make sure that we get that prosthetic fit to the patient, so it has to fit appropriately. This is with the use of occupational therapy, physical therapy, and specialized prosthetic nurses or providers, and they'll help fit that prosthetic device on so that it fits on that stump appropriately and doesn't cause any skin breakdown, and it can be used. Right after amputation, the patient's limb is going to be swollen, red, so we don't put a prosthetic on it right away. So what our focus is on post-surgery for amputation is muscle positioning, not muscle positioning, but positioning, and we want to make sure that we avoid muscle contractures. So when we cut off a limb, let's say I amputate my left leg, those muscles and tendons that attach my lower leg to my upper leg are then going to be severed, and so they're going to be cut. And so those muscles tend to want to shorten up or contract after surgery. And so those patients need to make sure that they keep their limbs stretched out to avoid contracture. So let's say I have my leg amputated. I want to make sure to keep my leg flat down on the bed, with frequent repositioning, but making sure not to put a pillow underneath my limb, okay? Because that lifts my limb up and can actually cause that muscle to decrease or contract, if that makes sense. So proper positioning post-surgery for an amputation is that we do not place pillows under the remaining limb. We can put them in a prone position, so rotating their positioning for about 30 minutes every couple hours, put them prone on their stomach, and that lets the leg actually decrease down or stretch down and helps to prevent contractures. So it helps keep it straightened out. We also want the patient to focus on things like nutrition, so high protein to help with wound healing and increasing vitamin C. As I said, it helps with collagen synthesis and can help promote healing of the wounds and get that limb healed up for our prosthetic.